Good morning. We welcome you to the Utah Physician Assistant Summit, which is sponsored by the Utah Academy of Physician Assistants. This meeting is dedicated to improving access and affordability of quality healthcare for Utahns. My name is Dr. Jonathan Baird. I am the immediate past president of the Utah Academy of Physician Assistants. I'd like to recognize legislators, executives, and administrators from systems, clinics, and other healthcare organizations, large and small, across Utah. We have leaders from professional and government organizations. And of course, we have our physician and PA colleagues. And we wish you all a very happy PA Week. Our program this morning will be roughly as follows. We will have the pleasure of hearing from Senator Deidre Henderson. We will be hearing from Dr. Jenny Coombs, President Kim McFarland, and President Tim McCreary, both of the Utah Academy of Physician Assistants. Following those remarks, we will have a brief break, and then we will transition into a panel discussion with the audience, addressing your questions and commentary. Those questions and commentary may be submitted using the chat button on your virtual dashboard. And now at this time, it'll be my pleasure to introduce our keynote speaker, Senator Deidre Henderson. She was elected to the Utah State Senate in 2012. She currently serves as the chair of the Senate Education Committee and previously chaired the Senate Revenue and Taxation Committee and the Senate Rules Committee. Senator Henderson is a champion of government transparency, advocates for low taxes, is dedicated to removing onerous regulation for Utah businesses, and has always been committed to listening to the voices of those who feel they are not being heard. She has been married to her husband Gabe for 27 years. They are the parents of 5 children, and I think I've heard a rumor that she's running for office again, but I'll let her tell you about that. Ladies and gentlemen, won't you please join me in welcoming Senator Deidre Henderson.
Thank you. Thank you. It's a pleasure to be here today. I'm honored to be asked to deliver a keynote address this morning. Again, my name is Deidre Henderson. I am a current Utah State Senator, and I'm the Republican nominee for Lieutenant Governor for the state of Utah, running with Spencer Cox. On August 6th this year, my husband, Gabe, tested positive for COVID-19. 2 days later, my oldest daughter, her husband, my youngest daughter, and I all tested positive as well. This happened 1 week before my third daughter's wedding, which, of course, we had to postpone. Thankfully, after 2 solid weeks of illness, my husband and children had all recovered completely. I, on the other hand, am still recovering, waiting for my lungs to heal, which is why I'm wearing this special fashion accessory right now, and I can't wait to be done with it. And the year 2020 has been probably one of the most difficult in our collective memories. But however unpleasant and unpredictable it's been overall, it certainly is not unprecedented. There have been perils and pandemics in the past. We can and should apply the lessons learned during the preceding world crises to this one. During the darkest days of World War II in 1939 and 1940, it was really difficult for the British people to imagine victory. But Winston Churchill never doubted. He rallied their spirits. By 1943, the war was beginning to turn in favor of the Allies. Still, Allied leaders were concerned about when the war would end and what that end would look like. In the spring of 1943, with an eye toward the future, Churchill outlined his bold post-war plans. However, he warned that too many people had jumped to the conclusion that the war would soon be over and they would be able to quickly resume life as they once knew it. "I'm not able to share these sanguine hopes," Churchill said. "The difficulties which will confront us will take all our highest qualities to overcome. but difficulties mastered are opportunities won. While today we are in the midst of a public health crisis that has tested not only the strength of our healthcare system and our economy, but also tested our highest qualities of goodwill and humanity. But there will be a time when this war is over too. Now is the time for us to prepare, to plan for the professional, individual, and collective opportunities to be won after we use our highest qualities to master the difficulties before us. How can we do this? Until COVID dominated just about everything in our lives, some of our biggest healthcare concerns from a legislative standpoint were the cost of life-saving medication, access to mental health services, healthcare provider shortages, and price transparency in medical care. These concerns haven't disappeared. In fact, some of them have only become more pressing and more apparent because of COVID. Last month, Governor Gary Herbert highlighted additional problems, such as people not receiving primary care due to limited access to clinics. He outlined how we are seeing cracks in our healthcare system as it's being pushed to its breaking point. We've known that there are potential discrepancies in the care that people receive based on their income, their ethnicity, and where they live. COVID has forced us to confront this painful fact. Throughout the summer, we saw evidence of this in Utah's Hispanic community, who have been disproportionately impacted by the pandemic. During the first few months of COVID, Hispanic and Latinos made up roughly 40% of the state's cases, while only accounting for 14% of our state's population. Why was this the case? The CDC, working with data from county health departments and the Utah Department of Health, released a report on this topic that covered the time period of early March through early June. As reported in the Salt Lake Tribune, the report found that systemic social inequalities have resulted in the overrepresentation of Hispanic and non-white workers in frontline occupations that are more likely to be exposed to coronavirus. The report concluded that Hispanic and non-white workers have less flexible work schedules, including less access to unpaid and sick leave policies and fewer telework options. This resulted in Hispanic and Latino workers contracting COVID more frequently, as seen in a particularly noteworthy outbreak at a beef processing plant in May, which left 385 workers sick. Worse yet, when Hispanic people became ill, they became more likely to have delayed treatment and more severe COVID symptoms. Fortunately, the report and research being done also pointed to strategies to fix what was broken, encouraging the use of culturally and linguistically responsive materials and messages which reach workers of racial and ethnic minority groups, especially those facing outbreaks at work. The state's unified command and local leaders have rolled up their sleeves on that front. As reported by the Deseret News just last week, statewide there has been a major emphasis on targeting testing, quarantine, and contact tracing, as well as an effort to create culturally appropriate public health messaging by local and state health workers, especially in Salt Lake County. This public health messaging was particularly effective in that it came from trusted partner organizations and community leaders with deep and personal ties with the Hispanic community. Altogether, these efforts are making a big difference. Today, Utah's Latino and Hispanic communities are seeing a decrease in case rates, even in the midst of an unfortunate surge in overall numbers. Instead of 40% of total cases being from our Hispanic and Latino communities, we're down to roughly 32%, and the daily share of these cases from that group is hovering much closer to the 14% of our population, which they represent. As the spokesman from the Utah Department of Health put it, while progress has been made, we want to get to a point where that community is not disproportionately affected whatsoever. What's happening right here in Utah, right now, with our Hispanic community is an example of one difficulty mastered and an opportunity won that must last longer than this current pandemic. We must apply these lessons for the long haul. And the needs being exposed by COVID-19 point us to many more changes that need to be made. We need more healthcare providers for all Utahns. We need better telehealth options for everyone, especially many suffering from substandard or lack of access to care in our rural communities. And it's time to improve the law so that physician assistants aren't hampered from getting the patients the care that they need. COVID is not just about exposing what's broken, of course. It's also reminding everyone that our healthcare workers are our heroes. We see all that you're putting into your work, and we couldn't be more grateful. A positive area to build on going forward is the tremendous team-based care that PAs are known for. I've learned more about this since my son-in-law, Josh, started PA school at Eastern Virginia Medical School. I've seen firsthand your extensive education is highly condensed with limited time off. I know about the hard work you put in. Josh has told me all about why the PA approach, with an emphasis on spending time with patients and providing compassionate care as a team, produces better outcomes. And it's no surprise to me that the US News ranked being a PA among the top 2 best jobs in healthcare this year, along with dentists at number 1 and physicians at number 5. However, I have heard from many, including Josh, and even my own physician, about how the burden of overwork and bureaucracy in our healthcare system is contributing to burnout. If you're feeling that, I'm sorry. I know how emotionally and physically exhausted you must be. And while I can't take that fatigue away from you, I hope to remind you how much you mean to all of us in Utah, and especially to my family and me. I've seen so many healthcare providers step up to take care of people. I've seen you become like proxy family members, providing for the emotional and mental health needs of so many hospitalized people who are needing to see loved ones but can't due to COVID. I'd like to tell you about a personal experience that my family had recently. On September 1st, my 2-year-old niece, Eliza, suffered 2nd and 3rd degree burns from the bottoms of her feet to the tops of her ankles from scalding bathwater. She spent the entire month of September in the University of Utah Burn Trauma ICU, where she had 2 skin graft surgeries. She was just released last Friday. The physical, emotional, and psychological toll of this terrible ordeal would have been bad under ordinary circumstances. But throw in a global pandemic, and you add a whole new layer of trauma to an already horrific situation. Because only one parent was allowed in the hospital at a time, my little sister and her husband had to divide care and had to be alone and isolated during this time of great difficulty. It was agony for the entire family to witness, but seemingly small things made such a big difference. Eliza's favorite nurse, Lincoln, took time to connect and build a relationship with her, which helped tremendously in getting little Eliza to do the painful things necessary for her to be able to heal. The charge nurse, PJ, who worked the night shift, he looked like Eliza's daddy, which she longed for. And one night, he held her for over an hour so that my sister could get some much needed sleep. And our family was touched by the videos of princess parades in which Eliza was wheeled down the hallways of the hospital, waving like royalty to all of the staff that were lined up as she rolled by. In our moments that are most difficult in our lives, we look to you, our healthcare providers. We rely on you. So I want you to know that in both good times and bad times, you have a friend and a supporter in me and so many others in state leadership. We're grateful to you. We want to help you. We want you to succeed. Our war with COVID may not be over yet, but as Winston Churchill once urged the people of Great Britain, so too should we use all our highest qualities to master our present difficulties in order to render them into opportunities. As a final thought, our current difficulties do not only require our highest qualities, they require us to lean on our highest quality people. I feel deep assurance that thanks to you, we are in good hands. Thank you, and God bless you.
our next speaker. She is an associate professor in the Department of Family and Preventative Medicine Division of Physician Assistant Studies. She graduated from the Utah Physician Assistant Program in 1991 with a certificate. She obtained her master in PA Studies in 2001 and her PhD in Public Health from the University of Utah in 2010. Ladies and gentlemen, please welcome to the stage Dr. Jennifer Coombs.
Hi, everyone. I'm very honored to be able to speak to you today, and I am in for Don Peterson, who has had a family emergency, and he is not able to be with you. So I know he was very honored to be asked to speak, and I'm also very honored. So the topic is 50 years of PA education and practice in Utah and the Intermountain West. And Don, our former director-in-chief of the Physician Assistant Studies and clinical professor emeritus, put together a very quick 50 years in 15 minutes. I know that's what we actually think about the last 7 months, right? Has been like 50 years. But when we talk about Utah PA demographics and some of the social circumstances that came with the founding of the profession, funding, PA program scholarship, and talk about degrees and applicants and regulation. And I really love this quote by Carl Sagan, which says, "You have to know the past to understand the present." So that is our goal. Here we're talking about the very latest from 2018 statistical profile of certified physician assistants, and we're talking about Utah. So here's the number of certified PAs, 1502, and that's people who are certified in Utah, but we know that the number of licensed PAs is actually 1791, and that's because some PAs maintain active licenses in more than one jurisdiction. Some of the other highlights of this slide are that 32.1% of PAs practice in primary care, and that's including family medicine, general practice, general internal medicine, and general pediatrics. The top practice settings, approximately 50%, is in an office-based private practice. And then also I want to point out to you the educational debt for recently certified PAs is a median of $137,000. They typically see 70 patients a week, and PAs have a payer mix in Utah of about 40% private insurance, 25% Medicare, and 15% Medicaid. Now let's just step back in time and talk about the 60s. The 60s was characterized by the Civil Rights Act and the Voting Rights Act. And there was a struggle for human rights and social justice. Of course, we still have a long way to go. In the 60s, healthcare was addressed. So what came out of the 60s, which really was kind of a post-World War II phenomena, was increasing technology, a decrease in primary care, and an increase in specialties. It also resulted in some really interesting things like Medicare and Medicaid, community health centers, and the physician assistant profession. Dr. Eugene Stead, of whose birthday is what we see as PA Day, and his birthday is celebrated as a week, as a PA week, which we're celebrating right now. He founded the PA profession in Duke in 1965, started with 4 Navy corpsmen, and it was a 2-year curriculum at Duke, and they graduated of their 3 first PAs in 1967. This is a picture of Dr. Stead. For Utah, we came out of the University of Washington, started a program. It was called the MedX model, and this is a picture of Dr. Dick Smith, who founded the PA program there at the University of Washington. Also returning medics from corpsmen from Vietnam. Interestingly, the idea of the term medics, it stood for medical extender, but it was also a play on words for the hospital medics. There are 4 pillars of the physician assistant profession. These should be in like 2 columns. So you can see there's credentialing, and then there's professional organizations. These 4 pillars have been very instrumental in having the success that we've had in this profession. First is the ARC-PA, which is the accreditation of all PA programs. Then the NCC-PA, which is the certification and recertification. And then over in the professional category for PAs, the American Academy of Physician Assistants, which was the AMA analog. So the American Medical Association analog was the American Academy of Physician Assistants. For PA programs, there's about 250 PA programs right now, and PAEA was founded in 1972, the analog being the AAMC. Now, the official journal was founded in Utah by Don Peterson, and that's the Journal of Physician Assistant Education. And actually, Don and I wrote an article for the 50th anniversary of the profession for a commemorative journal, and we wrote this article called Crafting a Profession, and we talked a lot about these 4 pillars of the profession. So credentialing, initially, there was a period of where the American Medical Association credentialed us, but then we took this over, took it on ourselves, and we have periodic reviews. The max number of years of accreditation for a PA program is 10 years. For graduates, initially, the physicians also took this on, and then we took it over and formed the NCCPA for an exam we call the PANCE, the Physician Assistant National Certifying Exam. And then we recertify now every 10 years. I, of course, have been a PA long enough that I remember the times when we recertified every 6 years, but now we're recertifying every 10 years. We have to have 100 hours of CME every 2 years. And now we also have certificates of added qualifications, CAQs, in specialty areas. And you can also see these on this other column, organizational representation, as being our partners in the certification of all of our graduates and what we're doing. So in Utah, we had a committee commissioned by then Governor Rampton in 1969, and this was the Rural Health Services Study Committee, and they issued a report. And they recommended that the University of Utah School of Medicine should create a Department of Community and Family Medicine, and the department should also start a physician assistant program. So in 1970, Governor Rampton, quote, "I have carefully reviewed the proposal to train physician assistants for general practitioners in rural communities. The program outline has my full and enthusiastic support, and I wish to give it the strongest possible endorsement." There were other things that happened during this time, and there was an air ambulance service, loan repayment program for rural practice, and some other legislative appropriations that happened at that time. So we started, it was called the physician assistant program where I work now, Utah Medics Project in 1970. And if you come up to our building, you can see the combat medic sculpture that was commissioned in 2003, which is really a nod to our military roots. Vietnam, corpsmen returning from Vietnam. So Utah PA program founders, Dr. Castle, who was actually a cardiologist, and he just died a few years ago, and Bill Wilson. He was our founding director of the Utah Medics Demonstration Project, which is now the Utah PA program. Love these old pictures. They started with a $50,000 grant and then later got grant funding under HRSA. We had co-sponsorship with the Utah Medical Association, and we've had that since 1970. And Dr. Peterson, Don wanted me to make sure that I said that he got a lot of support from Dr. Sorensen and Dr. Val Bateman, and also Michelle McComber, who is on the Utah Medical Association Executive Director. So we had our first class here. They were all return military medic and corpsmen, and we were in the 70s and 80s, mostly male, and then from 210 to 220, more like a quarter to 30% male. In the early days, we were the only PA program for this large Western version. And I love this slide because it shows the clinical sites for the first 1, 2, 3, 4 classes. And you can see we're spread out into rural areas throughout the West. PA programs have been leaders in evidence-based medicine, early clinical experiences for students, case-based education. We love interprofessional education, problem-based learning. We had a national model curriculum in clinical therapeutics. It was about 120 classroom hours. We have had 3 presidents of the Physician Assistant Education Association. And here you can see a picture of PA faculty Dave Cahey, who's teaching advocacy skills to PAEA health policy fellows, and he's now in Washington, D.C., working for the Physician Assistant Education Association there. We shared our evidence-based medicine curriculum across the campus and across the country. We have this clinical therapeutics model that we've also shared across the country, and here you can see PA faculty Connie Goldgar teaching evidence-based medicine to one of our first post-grad students. And don't you just love these pictures, because the computers are looking quite good. PAs do a lot of community engagement through service learning. We've had migrant worker outreach for 25 years, Native American outreach, Head Start. We participate in the Care Fair. We started a Hilldale outreach program down in southern Utah. We have a student-run clinic at Malahay that's a free clinic. And PA students also work at the free clinic in St. George. Community engagement and disaster relief around the world: Papua New Guinea, Thailand, Ghana, Guatemala, Nepal, the Netherlands. Disaster relief, and I want to note the 2005 Hurricane Katrina, Don Peterson, when he was working with the PA Foundation, was able to raise $80,000, and they built actually a rural clinic in Mississippi. So doing these kinds of outreach efforts for many years, and it's touched a lot of different communities worldwide, but also here at home. We've had also hosted delegations here. This is Owen from Papua New Guinea with Mike Langley, who was a PA student at the time. We've hosted these student elective international rotations, and we've also collaborated with other international institutions, and we've done workforce research and publications. So regulation from physician extender all the way to physician assistant. We've had full practice, full RX prescribing authority, 2 through 5 controlled substances successfully for over 30 years. And these changes have really been because of the excellent track record of our PA graduates and practice and expanding scope of practice in Utah. So there's been an evolution. I think this is really important to see this, because we started with this delegation amendment to the Physician Practice Act. We moved to the Comprehensive PA Practice Act in 1989. And now in 2020 and in 2021, new legislation is being proposed. And we have some issues: patient access, affordability, PA licensing board composition, PA supervision, legal liability, payment and accountability, team practice, and optimal team practice is proposed by AAPA. So we have some things we're moving forward. We've been a dynamic profession. We've enjoyed these incredible, the incredible work of those who have gone before us, but we now have some work ourselves to do. Utah PA practices have been in these interdependent teams with physicians and nurse practitioners. I can't mention this enough. Primary care, urban, rural practices, trauma teams at the IMC, PAs and NPs run the traumas and orchestrate the evaluation and management of patients. We have emergency medicine at the U of U. PAs and NPs provide care in the ER. They run the observation unit. Cancer care at Huntsman. Bone marrow transport. PAs and NPs manage very complex patients. We had a campus expansion to St. George in 2018. We have this excellent space. And so now we have 48 students and St. George has 20 from a total applicant pool approaching 3,000. And now we have new Utah PA programs, super exciting. Rocky Mountain University of Health Professions in 2015, and online for accreditation, Ogden, Weber State, Orem, Utah Valley University. So things are changing, things are moving forward. You can see we stand on the shoulders of some greatness. So PA Class 50, just want to say, we've always been out in the community. I wanted to highlight Ravina Talker, who's been down she's Navajo, she's been in Monument Valley Community Health Center. And our students, Class 50, decided to, collect PPE, and here they are. And they're going to send this down to one of our graduates down in southern Utah, or down in the Four Corners area. Currently 68 grads from 2 campuses with 3 additional programs total. Utah graduates, we're probably going to increase to about 150 a year or more of PAs trained in the medical model, over 2,000 clinical hours combined with 1,500 didactic hours. Super, super exciting and proud of what's happening. So Utah PA evolution, this is actually pretty it's a busy slide with a lot going on, but I wanted you to see that movement. I wanted you to see with this how in 1970 we started with the Utah MedX project, and now we've gone on and we're going to have more programs in Utah. Grant funded, now we're the University of Utah is tuition-based funded, and then we have UMA co-sponsorship that's been continuous. We've gone to 27 months, an average of 111 weeks in terms of our programs. Demonstration project, then moved to a master's degree. Delegatory regulation, now a comprehensive practice. So again, that movement forward in time, and we're part of that. We're part of that history. So rich, complex tapestry of people, places, and activities. We are going to hopefully celebrate our 50th anniversary, and we've moved it off a year, just like everything else. The pandemic has moved us off, so we're planning an even bigger party. And you can see a 50th anniversary book that is going to be coming out with all of this history. Thank you.
Please welcome to the stage our next speaker. He was raised in Price and hails from Green River, Utah, and as such, he loves rural Utah. He attended the University of Utah's PA program and has practiced medicine for 22 years, many of which happened in rural community health centers. He is a founding partner in Best Practices Incorporated, an EMR startup dedicated to improving the quality of medicine. He is currently employed by Intermountain Healthcare's Connect Care, a leader in the telemedicine field. His career has been defined by service. He has held numerous positions on the Utah Academy of Physician Assistants Board of Directors, including his current position as president-elect. He also sits on the University of Utah School of Medicine Alumni Board, the Emory County Public Lands Council, the Green River Canal Company Board, and the Green River City and Planning and Zoning Commission. Ladies and gentlemen, please welcome to the stage President-elect Kim McFarland.
Hey, thank you, Jonathan. I always think that they're talking about someone else because I'm not that good. But it is truly a pleasure to come and represent the PAs of Utah and talk about things that are important to our profession. The profession was founded in 1965. That happens to be the year that I was born. As you can see, I am now a little bald and a little gray, and hopefully have grown up a little bit in that time. And as Jenny pointed out, the PA profession has grown as well. We have been proven to be excellent healthcare providers and a valuable resource to patients particularly in rural and underserved areas where I have served the majority of my career. And so we'd like to talk about some of the issues and facts and solutions that we propose to increase patient access to care and the ability of PAs to provide some of that care. And we realize that we are only a part of the solution to healthcare problems, and that our small slice is a small slice of the pie of the healthcare industry. But it's important to those patients that we serve. Having practiced for most of my career in rural medicine, many of those patients don't have another option. And so if we can provide high quality providers into rural areas and other areas that need our services, then we should eliminate the barriers that allow that to happen. So Jenny pointed out some statistics. This was from 2019. We met with Doppel last month, and they said that the number of PAs licensed in Utah is over 2,000 now. So we continue to grow as a profession. Some of the issues that we are facing. Current model is a supervising physician model. As physicians become more employed, and versus the old model of having a solo physician in a private practice, they're now more employed. PAs are also becoming employees of those institutions. And that changes the dynamics of the PA physician relationship. Frequently, the supervising physician at my last two jobs was not the one that hired me. It was the organization that hired me. They were assigned to supervise me without even knowing me. And so that creates some tension there sometimes. And under the current model, they assume some liability for the PAs that they supervise, even when they don't see those patients, and even if they're not in the same office as the PA that's providing the service. We also have some limitations on scope of practice. Sometimes PAs, they frequently have three or more specialties and career changes from specialty to specialty throughout their career. And sometimes they develop a specific skill set in one of those specialties that as they move to their next specialty, they're not allowed to use anymore because their supervising physician, it isn't part of their normal scope of practice. It is important to recognize that PAs are always taught to work on healthcare teams. We want to continue to be part of the team. We're not redefining the team, just removing some of the barriers, the legal barriers that impact that team and prevent it from functioning at its full capacity. We also have some billing issues. PAs historically have not been able to bill directly for their services. This hides the PA's contribution to medicine when we do data research, and doesn't allow us to fully understand the impact of the PA profession on the total healthcare world. In the current environment of medicine, there are new contracting opportunities and new employment models that if you can't bill directly for your services, it impedes that ability to participate in some of those models. And it prevents us from being listed as Medicaid providers for Medicaid specifically. Our current medical board, or current physician assistant board, is made up of 3 PAs, 3 physicians, and a layperson. And so we'd like to talk about some of the facts. So John did a nice survey last year, and he can talk about all of the statistical relevance of that. It's way over my head, but it was a pertinent survey, and we proved that it was relevant and that the data was significant. And so some of the questions that we asked were, many physicians or PAs work in group practices or hospital settings where laws require PA and physician agreements and those agreements interfere with their ability to make practice level decisions in patient care teams. As a PA, have you personally been affected by this? And while we see the majority of PAs, 56% have not necessarily been affected by this, we notice that at least a third definitely have, and another 13% think that they might have been. The important thing is some of the questions, some of the answers and responses that came out of that is, I am trained to do things that my supervising physician does not do. My hiring was delayed because they had met their maximum number of PAs per physician. My prior employer, the physician, was very disengaged and did it just for the pay, but didn't care about the practice. I work with many different MDs and rarely with the MD who has signed the PA agreement. The MD that I practice with sometimes has a different opinion about the patient care than the MD which has signed my PA agreement. This is a real conflict. Another one, currently, retirement, sudden relocation, disability, or death of a physician with whom a PA has a delegation of services agreement, or a DOSA, may mean that the PA can no longer provide healthcare service to the patients, even if the patient has been their primary care provider. As a PA, have you personally been affected by this issue? And do you worry about this issue? Were the 2 questions that we asked on this. So, have you personally been affected by this issue? The vast majority of PAs have not, but 11% have been affected by it. And that was a real effect to their patients. What's more telling is, do you worry about this? More than half of the PAs worry about this issue. And only a quarter think that it's not an issue. So the responses here: a former supervising physician got injured and was unable to operate. I had to go and find other work with other doctors. I experienced a problem with my supervising physician relocating in the past and worry it may happen again. I had to find a new job and leave my patient population when my supervising physician retired, and my current supervising physician is planning to retire before I am. That means those patients are not going to be able to receive the same care from the same provider. So on direct payment, PAs are not eligible for direct payment from Medicare and nearly all commercial payers. Most payers require that payment be made to the PA's employer, which can unintentionally limit PA's employment opportunities. It also makes it nearly impossible to collect practice data for PAs because everything is linked to the physician. As a PA, have you been personally affected by this issue? 58% have. Only a quarter of PAs have not. Some of the comments. This hurts patients' access to Medicaid as medications cannot see me directly. Intermountain has suggested that I do not see Medicaid patients through their billing practices. I work for Medicaid or for Intermountain, and I see Medicaid patients all the time, but there are some issues in different clinics with that. My patients don't even recognize the name of my supervising physician on their insurance bills, so they get confused. Obtaining billing data is difficult and not well communicated in our practice. I have been in a position where I'm expected to meet a quota or level of billing and collection. As many aspects of my position are not billed directly under me, administration only looks at those numbers and not the actual work. I fear that without proper representation of me, which is often only done through the supervising physician, that may never happen, and that administration only has payment sheets to derive productivity and therefore my worth. Regulation. So we talked about the PA board. So in Utah, physicians are regulated by a medical board composed of physicians. Nurses are regulated by the nursing board made up of nurses. PAs are regulated by a board that has 3 physicians, only 2 of which are required to have experience working with PAs. 3 PAs and a layperson member also constitute that. Some argue PAs, or at least a PA majority, should constitute the makeup of the regulatory board. Do you agree with this statement? Overwhelmingly, PAs think that we should have a board that has a majority PA board. PAs, some of the comments on this, PAs should have the best understanding of the profession and have a majority on the regulatory panel similar to other professions. I do like that physicians are included, but this board should mainly entail PAs, maybe a 2-to-1 ratio or something. PAs who have practiced in the field understand the ins and outs of the profession. I believe it is very beneficial to have physicians supporting our profession. The PAs should have a majority, and we should strive to continue to have the great support of our professional colleagues in UMA. Jenny talked about this a little bit in her history of the PA profession. The UMA and physicians throughout the state have helped champion our profession. We want to continue to respect that, and we appreciate their and value their working with us, and hope that as we as a profession grow, we see a little bit more control over our profession and a little bit more personal involvement in our profession through boards like this. When a PA has a specific supervising physician by delegation of services agreement, their employers may lack flexibility in creating healthcare teams. The agreement also allows for physician liability for care that PAs provide when physicians are not involved, and physicians and employer risk for disciplinary action for administrative reasons. As a PA, have you personally been affected by this issue? So we only see 20% that have been directly related. But it needs to be pointed out that this was pre-COVID, this survey was. And from anecdotal reports, since COVID, with redeployment and employment changes and things like that, this is a significant issue for PAs in how they practice, is that that DOSA limits our flexibility in the workplace. And being tethered to one physician to a PA, that limits our ability to flex during a disaster or at other times when we're needed. Okay. So I currently work for a large employer, and to cover in a different department, I have to have additional supervising physicians. This creates additional paperwork and administrative burden in tracking and monitoring which physician I am working under on which day. I am often asked to see a patient for a physician in my same practice, which I do not have a delegation of services agreement for. As more and more PAs and physician work in groups, what motivates MDs to take on this risk when they don't actually own the practice, as was the model in the past? And this is one of the challenges that we're seeing. So we want to talk about solutions. So I think importantly, PAs should be liable for the care that they provide and fully responsible for that. Physicians not involved in the care of a patient shouldn't be liable for the care of that patient if they're not involved in that patient's care. That's part of maturing as a profession. The other thing that we propose is to eliminate the legal requirement for a specific relationship between a PA, between a specific PA and a specific physician or any other healthcare provider in order for the PA to practice to the full extent of their education, training, and experience. So we still want to be part of teams. We want to be part of the healthcare team. But, you know, we talked about, there's an example of some surgical PAs. They have 36 physicians as their listed as their supervising physicians. They have to go and collect signatures every time a change is made. If a new physician comes into the group, they have to go and get a signature. Whereas there are other models that would allow that to happen only at the employer level and be much smoother and less burdensome to both the employer, to the PA, and to the physicians that supervise them. Okay. For the Doppel board, we propose changing the ratio and having, currently it's at 3 physicians, 3 PAs, and a layperson. We would like to have 2 physicians and 4 PAs and a layperson on that board. And as we saw, PAs desire more responsibility for their profession. But we still want physician involvement. We think that that's important to hear their voice at that table. PA modernization, direct payment. CMS has recently made changes in their statute that allow for PA billing to be determined at the state level. And that is that, so if in Utah we make the change that says that PAs can bill directly, then PAs will be able to bill Medicare, Medicaid, be able to be listed as Medicaid providers, and be able to bill private insurers as well. We hope that that reimbursement model will be based on quality of care and not just a reduced reimbursement rate because we're PAs and not physicians. But if our quality is the same, then we would be able to provide the same, get the same reimbursement. Okay. We believe that patients will have greater access to high quality health care. Employers will have more flexibility with their workforce. Legislators will see increased access and lower Medicaid costs in their states, and physicians will be relieved of unnecessary administrative and legal burdens. There is national support for this. Bill Freinerfach from the National Association of Rural Health Clinics says the changes PAs are seeking represent a natural evolution of the PA profession. Patients, especially in rural and underserved areas, will benefit from greater access to the high-quality care PAs provide. The Brookings Institution Hamilton Project, Dr. Adams and Dr. Markowitz, support PA modernization, removing unnecessary restrictions on PA practice, such as eliminating the requirement for PAs to have an agreement with a specific physician in order to practice, would help alleviate healthcare shortages and improve efficiency with no adverse effects on patient outcomes. The Departments of Health and Human Services, the Treasury, and Labor Department in 2018 produced a report called Reforming America's Healthcare Through Choice and Competition. In there, they stated that states should consider eliminating requirements for rigid collaborative practice and supervisory agreements between physicians and their care extenders, such as physician assistants. Thank you. We'd hoped to have some formal language for the bill today, but you know, we'll blame it on COVID, as COVID has slowed everything else. The wheels of government sometimes are slow in turning, and we expect the formal language of the bill, of the first draft, to come out later this week or the first part of next week, and we will share that with all of the participants of this conference as soon as it's available.
Please welcome to the stage our next speaker. He is a commander with the United States Public Health Service stationed in northeastern Utah. He provides ambulatory psychiatric care for thousands of Native Americans living in Utah and is dedicated to leadership and advocacy for the PA profession in Utah and across the country. He has served as the president of the Public Health Service Academy of Physician Assistants, is the current president of the Utah Academy of Physician Assistants, and is the current director of the psychiatry track for the Doctorate of Medical Science program at Rocky Mountain University of Health Professions. He has been recognized for his humanitarian efforts abroad and his dedication to underserved and vulnerable communities on America's Indian reservations. His work in the House of Delegates for the American Academy of Physician Assistants aided in the passage of what is known as optimal team practice, and he was the lead author in a recently published revised PA scope of practice policy that allows Indian Health Service PAs full practice authority as vital members of the healthcare team. Ladies and gentlemen, please welcome to the stage Dr. Tim McCreary.
Thank you very much, my esteemed colleagues, and for that generous introduction. I'm so grateful to be able to have this chance to be with you in this moment, this pivotal moment in our history. I feel it a great honor to be serving the PAs of Utah, and I'm committed to seeing that whatever we do makes a better practice environment for you and your patients. So just as we've talked about the inclusion of modification or modernization of statute to allow PAs to work at the top of their training in their various areas of work, we are also introducing another change or proposing another change in statute, and that's impacting the Mental Health Practice Act. So I wanted to acknowledge for a minute, as we've met with our external stakeholders in this discussion, such as the psychologists, the psychiatrists, the psychiatric mental health nurse practitioners, licensed clinical mental health counselors, and others, that this is really a sacred space. We acknowledge that the work that's being done for our patients here in Utah, our clients, is in a very special place. You know, I began my career with the Indian Health Service about 15 years ago, and I was serving in a primary care role, but I found that there was more and more work that I was doing with people who had mental or substance use issues that needed more training than I then had. So I began studying something called motivational interviewing, which helps keep an even relationship with providers and their patients or clients, and meets them where they're at in their process of change. I remember a particular patient, the first year of my career. He came into the clinic. I'd never met him before, a man in his late 50s. He said to me, Tim, this morning, I woke up in a ditch. I don't know how I got there, and I'm scared. And I listened as he told me that he was struggling with alcohol use disorder. Unfortunately, he also had epilepsy. When these conditions combine, it creates a very fatal scenario because alcohol reduces the seizure threshold, and they have seizures in unexpected times and places. I realized that this was a sacred space. In that moment, in that exam room, and I listened to his story, and I wanted to help, but I didn't know how. He was dead 8 months later. So who did he need? Well, we'd all like to have a psychiatrist on call right next to us to come in those moments in primary care. The problem is there's a national shortage of psychiatrists. Statistics tell us that this shortage is profound. Fewer than half of the counties in the United States have psychiatrists. And more mental health is being managed in primary care settings. Unfortunately, these statistics seem to indicate that the situation will not be any better anytime soon. And we're expected to see this shortage of psychiatrists peak here in about 4 years in 2024. Mental illness is quickly becoming one of the most costly aspects of medical care being delivered in the United States today. And that's not even counting the social impacts of unmanaged mental illness. We see incarceration rates, reincarceration rates. We see patients falling through the cracks as they are struggling with their substance use disorder, becoming imprisoned, families without fathers, families without mothers, children who are neglected and abused, all because of untreated psychiatric conditions. According to the Bureau of Labor and Statistics, the situation in Utah is even worse than it is nationally. There are only 209 mental health providers per 100,000 people in Utah. And this includes not just our psychiatrists or psychiatric mental health nurse practitioners, but also psychologists, licensed clinical social workers, and others. Suicide. We rank 5th in Utah for suicide deaths. Unfortunately, 45% of those who complete suicide will have seen a primary care provider within a month of their death by suicide. The opioid epidemic is claiming more lives than automobile accidents or homicides by firearm in 2017 nationally. And in Utah, it's even worse. This can feel pretty overwhelming. These are sobering facts. I attended General Conference this year, and I heard a talk given by a sister who shared this quote, and it stuck with me it resonated with me so profoundly with this issue that I wanted to share it with you. This is from the Old Testament, 2 Kings 6:15 through 17. And when the servant of Elijah was risen early and had gone forth, behold, an host compassed the city both with horses and chariots. And his servant said unto him, Alas, my master, how shall we do? And Elisha said, Fear not, for they that be with us are more than they that be with him. He conveyed reassurance that they would be okay. But then he also, Elisha prayed and asked God to show his servant what was real. And he said, Open his eyes that he may see. And the Lord opened the eyes of the young man, and he saw. And behold, the mountain was full of horses and chariots and fire round about Elisha. We want, if nothing else, to achieve is for our partners in mental health to see us, to know that mental health PAs are here. We're working now. We're working in every setting in mental health in Utah. And we're highly trained, and we're ready to work and partner in delivering better health care, better mental health services, and increasing access to mental health care services. This slide here shows the Practice Act that we're looking to insert the PA profession in. It's Chapter 60. This is State Statute 5860-101. In this statute, we're conveying, this is where it represents where these mental health, what professions can perform mental health in Utah. And we've gone through those. Here's a list of those: clinical social workers, marriage and family therapists, clinical mental health counselors, and so forth. Noticeably absent are PAs, and we hope to change that. So here's an example of an analog profession, a psychiatric nurse practitioner, mental health nurse practitioner. These are wonderful professionals, and I just want to say, having worked with several in professional capacities, having been led by one as a director at a clinic and being deployed overseas with psychiatric nurse practitioners, how skillful these professionals are. In Utah statute, one of the ways a nurse practitioner can work in mental health is by completing a postgraduate or postmaster's transition certificate program. It takes about 18 months to 2 years and will include some practicum, such as 4,000 hours of combined of education involving clinical care. 3,000 of those would be working with other mental health providers under a supervised capacity, and as well as passing a mental health board exam that verifies their knowledge. So PAs, and I know there's been much discussion already about who PAs are and what we bring to the table, but here's a brief review of that. PAs pursue a course of education that is 3 academic years. It's highly competitive. For those of you who don't know, the UPAP had 1,800 applicants for 68 seats in 2019, meaning their admission rate was about 3%. So if you made it into UAPA, feel free to buy a lottery ticket over the border because you are a very lucky individual. And so we have a very skilled, this is very competitive. And they bring with them, they come from all different walks of life, and they bring with them, on average, 3,000 hours of direct patient care from an allied health profession. So PA curriculum is very rigorous. Many of us say it's like drinking from a fire hose. I think that is a good analogy. And those who can survive it come out very well prepared to continue their education throughout their lives. It also includes 2,000 hours of clinical rotations in medical and surgical disciplines, including family medicine, internal medicine, obstetrics and gynecology, pediatrics, general surgery, and psychiatry. So what we're proposing for this, the inclusion of PAs in the Mental Health Practice Act, is really twofold. The first is that we want all PAs to be recognized in the mental health statute. Those who are working with psychiatrists and working for sharing the same patients and doing the same kind of work, they should be recognized. But also for those PAs who pursue additional training, as I have done, will be able to be recognized as autonomous providers and have their scope of practice determined by their individual training and experience. Some of these proposed criteria are 4,000 hours of clinical practice with a psychiatrist, and 1,000 of those will be with a supervised mental health therapist doing therapy and learning therapy. And also to obtain an advanced degree such as a doctorate of medical science that includes a review of the ACGME didactic education, including the core competencies of psychiatrists. So we'll follow the same curriculum that psychiatrists get during their 4 or 5 year psychiatric residency. We also propose that they successfully pass the NCCPA certification in psychiatry and achieve the certificate of adequate qualification in psychiatry. As with other PAs, achieving these milestones will allow them to perform in an autonomous fashion where they're working. Where I work in rural northeastern Utah, they call it the Tri-County area. There's Daggett, Uinta, and Duchesne counties. There's about 50,000 people that live there. Guess how many psychiatrists we have? You guessed it, not one. And so there's a psychiatric nurse practitioner who's actually still in training to get her certificate, and there's me. And we're trying to care for the complex needs of a large group of people. On our Native American reservations, we have a tremendous amount of substance use, which then leads to psychosis and forms of schizophrenia. And I manage many cases of uncontrolled psychosis in concert with their substance abuse. And so it's a very challenging place, but with extra skills that psychiatric PAs can obtain, it's doable. And I can go home every day and live my normal daily life and then go back to work excited for the next day of challenges. Studying things like CBT and motivational interviewing and understanding the neurological conditions on a deeper neuropsychological level, we're able to deliver care that will not only help the PA go home and keep his sanity and go back to work, but also improve the care that's happening for patients wherever they're at. And that includes primary care clinics. I just wanted to end with this quote. David Brooks is a columnist for the New York Times. He said, "Many of society's great problems flow from people feeling not seen and known." There's a core trait that we all need to get better at, and that is the trait of seeing each other deeply and being deeply seen. As we've gone through this process and met with other professions, I have to say I've learned that there is a culture within each profession, and we are all of us outsiders to those cultural places. As we've come together, either virtually or in person, we've been able to bridge some of those cultural barriers and learn about each other's needs and recognize that we're all treating the same patients. I can say that I can look more deeply now into what psychiatrists go through during their rigorous residencies and what psychiatric nurse practitioners experience every day as they face catastrophic, debilitating conditions in people's lives. I just want all PAs to know that we have a place here in mental health. I want the employers and our colleagues in other professions to recognize that PAs are here to help, that we're part of the team, and we are willing to look deeply and allowing you to also see deeply into who we are. Thank you.
We once again express our gratitude for our speakers this morning. You have given us much to think about and much, frankly, that we would like to talk about, and we'll have the opportunity to do so, both in person as well as virtually. Those of you at home, you'll notice the chat button at the bottom of your screen most likely. If you click on that, you'll be able to submit questions and commentary that we will hope to fit into our discussion in a moment. We are going to adjourn briefly for 5 minutes while we set up for that panel discussion, and we will see you back here when that 5 minutes is over. Welcome back. As you see before you, we have some of our esteemed colleagues, and I would like to take the moment to introduce them. On your right is Dr. Brian Shiozawa. He is the Associate Vice President for Health Policy and Associate Professor of Surgery, Division of Emergency Medicine at University of Utah Health Sciences. From 2017 to 2019, Dr. Shiozawa served as the Regional Director for the U.S. Department of Health and Human Services. Appointed by the President, Dr. Shiozawa oversaw operations of HHS for Region 8, and that includes Utah, Colorado, North Dakota, South Dakota, Wyoming, and Montana. He is a board-certified emergency physician and practiced full-time at St. Mark's Hospital Emergency Department and served in the highest levels of leadership at that hospital. He has also served as president of the Utah chapter of the American College of Emergency Physicians and the Utah Medical Association. Additionally, he has served 2 terms in the Utah State Senate, chairing the Business, Economic Development, and Labor Appropriations Committees, and served on many other committees. During his terms, he has passed as sponsor or co-sponsor over 50 bills, many helping to ensure the health and well-being of Utahns. Please welcome with me Dr. Brian Shiozawa. Our next panelist is Dr. Timothy McCreary, whom we have already heard from. Dr. McCreary is here in several capacities, not the least of which is as president of the Utah Academy of Physician Assistants, and he speaks on behalf of the organization, in addition to his experience as a clinician provider in the services of psychiatry, which he has already mentioned to us. Please welcome to the stage once again, Dr. Timothy McCreary. Seated next to Dr. Shiazawa is our esteemed colleague, Michelle Lyman. Her journey is quite unique. She graduated from the University of Utah PA program and has practiced medicine for 25 years. Her work reflects a commitment to rural Utah, the city of Blanding, and the people in the Four Corners region. She has helped pioneer the Utah Navajo health system. In 2005, Michelle was recruited by the National Health Service in the United Kingdom to help pioneer the PA profession in Ireland, Scotland, England, and Wales. She was charged with recruiting PAs from the US, placing them in all manner of clinical settings, and educating physicians in the UK on how to utilize PAs in their practices. She helped to write the curriculum for 2 now thriving PA schools in Birmingham and Manchester, England. After returning to the States, Michelle was recruited by Utah State University President Stan Albrecht to accept the position of Director of Health Professions for Utah State University and oversees 7 health profession programs across all the USU statewide campuses. Please welcome to the stage, Michelle Lyman. Finally, seated next to Dr. McCreary is Chris Heyer. He is Intermountain Healthcare's Executive Director for Advanced Practice Providers and provides strategic leadership for over 1,000 employed and 600 affiliated nurse practitioners, physician assistants, nurse midwives, and certified nurse anesthetists across the Intermountain system. He is a skilled physician assistant who has successfully served in both clinical and leadership roles. He's passionate about caring for the underserved, committed to finding ways to make healthcare better, more accessible, and more affordable. Ladies and gentlemen, Chris Heyer. Panelists, thank you for being here today. We have listened to, I think, many great talks this morning, and we look forward now to dialoguing about that. We've heard first from Kim McFarland discussing what is proposed in the PA Modernization Act. And I wonder if I could get each of your responses to his words. And if we could, let's limit our responses to about 2 minutes. And if it's okay, why don't I go ahead and start with Michelle Lyman.
Okay, I personally have seen I work right on the border of the Utah Navajo Reservation. And I too have seen the need for mental health care in that region. We have behavioral health. We now have a behavioral health unit in Utah Navajo Health Systems. And I think it's going to be very important to see that we extend that care. I would love to see PA start practicing in that area. And with this legislation, it's going to be a boon to seriously underserved populations in rural Utah for mental health. Right now, there just is such limited access to mental health care, and often we're seeing improvements, but often throughout 25 years of practice, I've seen patients that have succumbed to their mental illness simply because there isn't access to care. So this is exciting. This is a wonderful, wonderful thing that we're doing.
Indeed. And thank you, Tim, for bringing up the topic there. To the other point, as far as Mr. McFarland's commentary, did you have any additional thoughts to add on what he said?
No, I think I've pretty much said it.
Let me turn our attention then to Mr. Chris Heyer. You're in a unique position here as far as how this law may affect your system. And I wonder if I could get your responses to the presentation by Mr. McFarland.
Sure, yeah, thanks, John. It's an honor to be on the stage with such great colleagues. Yeah, you know, I'm here as a PA myself who's worked mostly in underserved family medicine for 12 years now. I've had the fortune of now working for Intermountain Healthcare, representing their advanced practice provider group, but mostly here kind of for myself, seeking to understand a little bit more about what's being proposed. As a PA who's worked in family medicine and certainly seen a lot of similar challenges that patients who delay care or can't access care certainly face. You know, I think, I mean, it's been quoted numerous times that healthcare is now a team-based sport, is a team sport. My favorite analogy is that we need to train physicians to be basketball players instead of golfers, which always kind of rang true with me that, and I think a lot of the training is moving towards that area and training us all to be better members of a team. You know, and coming from my background that very much values the physician contributions to my career and my profession and my development, I'm really interested in learning more about the physician-PA relationship today, and kind of studying that and understanding what this legislative change potentially can do to that. And I think it has a lot of opportunity to really help us potentially remove some of the barriers to care that exist in our wonderful state. And just wanted to also thank the incredible team that's put together a lot of this work on outside of their regular jobs, I'm sure. So just excited to be here. Thanks.
Thank you, sir. Dr. McCreary, your thoughts?
Well, thank you. I have to say, I've heard Kim McFarland do that presentation a few times, and we had the very best version of it here today, and it was splendid. You know, these are issues that we faced in the Indian Health Service, and I have to say, I'm speaking for myself here. I can't speak for an agency of the government, but I have to say, this kind of change is what we needed in order to achieve the access that we needed for patients. And that's why our physician and other administrative leadership supported this concept of PAs working at the top of their license, working on teams in different places and different settings, depending on what access there was and which professions worked at this various sites. These are rural, underserved areas all. And not everyone has a specialist in those sites. And so PAs really do need to step up their game and do all that they can for these patients to deliver the care they need. And that occasionally, little administrative rules get in the way of that. And so to me, I see this as an extension of the work that we were doing and just trying to clear the path a little bit so that all the care members of the healthcare team can work at the top of their license. Physicians aren't being held responsible for the acts of another professional who may or may not be trained to do what they're doing. And it should be that everyone's doing what they're trained to do. So that scope of practice ought to be determined by the individual's training and experience and not someone else's. So I see this as a way forward for care delivery, especially in rural parts of the state. And I think that it'll be good for employers to not have to make sure that all the T's are crossed and the I's are dotted when it comes time to go before a court, and to remove those unnecessary liabilities, naming our physician colleagues in suits that had nothing to do with what was going on. Being able to let the physicians focus on what they need to do, which is the highly specialized work they're trained to do, instead of just worrying about what their PA is doing or their 4 PAs might be doing. So I'm excited for that, and I see this opportunity too for direct billing to be a way of really improving our transparency about who's doing what in healthcare in Utah.
And thank you for bringing up our physician colleagues in all of this. And I turn our attention now to Dr. Shiazawa, who is amongst the many hats that he wears, not the least of which is that of a physician and one who has worked with all sorts of providers, PAs included among them. I wonder if we could get your thoughts.
Well, first of all, thank you for including me with this distinguished panel. And I've learned a great deal this morning about my physician assistant colleagues. And I thought I was pretty knowledgeable about this. And so I've learned a lot of very interesting and useful things as we go forward. Let me just say it was a real honor to work with the UAPA when I was in the Senate and working on delegation of services and making the practice more efficient. And after all, the goals that the people in the PA and the medical profession have, it's what? It's to improve access for patients, to make it affordable, and to ensure high quality. And as we look at this particular act, and I'll direct some comments to that, when I was regional director for the Indian Health Service, I've been to places like South Dakota and the problems at Pine Ridge and Rosebud, Sioux reservations. And we desperately needed doctors, nurses, PAs to help staff those areas that were underserved and had exactly those problems that you so vividly described. These are real and they happen every day. And so, as demonstrated in that project, having groups of people who can reach out and who are willing to deliver high quality care in these various environments, which are so challenging to move, say, a family doctor and his or her family to the PAs were a very valuable part of that. And we recognize that at HHS. Everything from the opiate and substance abuse and mental health areas, also with homelessness and areas to reach out there, Indian Health Service. And so the PA group is such a vital group. One thing I was surprised to see is how many PAs there are in the state of Utah and how widely dispersed there are. So in the upcoming comments, I'd love to talk about my experiences in working with them in various environments, but grateful to be part of this group today.
Thank you. Additionally, because we are talking about 2 separate acts here, I'd like to get your brief responses as well on specifically PAs in the Mental Health Practice Act, and perhaps we can lead off here with Chris Hyatt, your thoughts as you hear that presentation.
Yeah, thanks. I think it was a great presentation, and learning more. I'd like to learn more from Tim as well on specifically the therapy training that I think goes into sort of the postgraduate phase, right? As you work towards your CAQ, understanding what that therapy training provides. And then I do have a question, I think is discussed with Psych APRN, our wonderful Psych APRN colleagues who provide so many of these services as well, on their therapy training and the equivalence of what they get compared to how therapy would come into a CAQ prepared psych PA, and how that could relate and potentially affect patient care.
Well, why don't we shift that question next door? And Tim, do you want to respond to that?
Oh, certainly. So I'm glad you mentioned that the Psych APRN role. They play a tremendous role in increasing access to care, especially in rural parts of the state. I know that Michelle was mentioning the other day that the only mental health prescriber that she has is a psychiatric nurse practitioner down in Blanding. So they perform amazing work. I see their training as remarkable. When they finish their nurse practitioner core courses, they also receive training in 2 modalities of psychotherapy, and that it introduces those the basis of their of therapy. You have to kind of have a grounding, in the theory of therapy, what it's purported to do, and then how to do it. And then after that, there's a supervision requirement. So they'll be supervised by other, say, psychiatric nurse practitioners or other licensed therapists to watch them do and see that they're doing if they know what they're doing. And we propose that really we do the same thing for PAs.
Sure.
So 2 modalities of therapy, which would be instructed at the graduate level, and then that would be taught by licensed therapists. Then they would receive the same requirement for supervision in their therapy.
Tim, let me follow up, with that. You use the term psychotherapy, and I wonder if we could be more broad in terms of how we describe that. How is training a PA in psychotherapy at all different than the training they already receive, when they graduate from PA school?
Great question. Thank you, John. Well, as we've mentioned, the PA education is rigorous. And they try to fit a lot in there. And in the earliest presentation about the history of the PA profession, Eugene Stead didn't just kind of pull this curriculum out of his hat. It was developed by the doctors to fast track physician education for preparing doctors for World War II. And so that's where the PA curriculum came from originally. And so there's a lot that's compressed into those 3 academic years, and there just isn't enough to train every PA in psychotherapy. So,
and when you say psychotherapy, you're talking talk therapy? Is that what we're to interpret by that?
That's right. So psychotherapy being talk therapy, interpersonal therapy, group therapy, couples therapy. It's where medicine is not necessarily used. So that's an entire discipline in its own. That's practiced by several different professionals.
And that's governed by the Mental Health Practice Act, not the Medical Practice Act, correct?
Absolutely. And in order to get a provider recognized on that Practice Act, they have to be able to do psychotherapy. So PAs currently that's not included in the ARC-PA, PAEA curriculum. And so that would be something done post-graduation. The CAQ in psychiatry essentially affirms that they have a grounding in the specialty of psychiatry, but with a focus on medications and medical management. So that would be something that additional training would be required in addition to the CAQ that PAs can earn, or that they might be learning on the job working with psychiatrists on a day-to-day basis. And by the way, they fill amazing roles. I have a colleague that's here with us at the Summit who is Ariana, who is working for uni at the Neuropsychiatric Institute, and she cares for really profoundly ill psychiatric patients who don't meet criteria for admission but can't stay in the ER. And so the uni trusts her with just taking care of them all night long, where she works the graveyard shift, and she does a great job.
Dr. Shizawa,
Thanks.
On hearing that, I guess the question that I would pose to you is, and being able to see it from your perspective across multiple health systems and states, is there a place then for PAs with this type of training as being described to fill roles in psychiatric care?
Well, that is the critical question that's going to come up in the legislature and when this bill comes up, because it will address this particular issue. And I totally agree. We have a critical shortage of psychiatrists in this state and in this country. And it doesn't matter whether it's substance abuse, mental health issues, suicide, whatever it is, we have a critical shortage of psychiatrists. And so we use great organizations like UNI, for example, to develop and develop programs and treat this underserved population, which is growing, by the way, in the pandemic, as we all know. So one of the things that will be critical in order for this bill to progress and to fulfill the goal of providing more timely access for psychiatric patients, for substance abuse and other mental health problems, is assuring the public and the medical community that those who have this certification are in fact have that quality of training so they can deliver in their scope of practice this same quality of care that we have come to expect. And so that's why it's important to know what type of training and how many clinical hours, the certification tests, and possibly recertifications tests downstream. If PAs, for example, have to take a repeat exam every 10 years, like emergency docs, why not also have a refresher or recertification in 10 years on this? If this type of quality can be guaranteed by the PAs, this will do much to further this bill from going forward. We critically need the help. For example, let me just talk, John, about one thing. As you know, that we're going to be developing here in Salt Lake County some receiving centers. Now, these will be sites where patients can go to be seen outside of an ER if they have mental health or substance abuse. And they can be seen there by practitioners who are specially trained and take care of these patients. They'll be open 24 hours, but we need trained personnel in these situations to take care of them. It will improve the efficiency of the healthcare system, keep them out of our ERs, and it will give them better care that's germane to their care. And so, John, I agree with the principles on this. Now, what we need to do is get the details and go forward and have discussions with the medical profession to understand this better.
And the details seem to be that you're looking for, would it be, what are the training parameters in terms of presumably hours? How is that training verified as far as certifications, and then re-verified over a period of time? Do I understand you correctly?
I think those would be essential things to go forward. And I know the Utah Medical Association is very interested in having this dialogue to go forward. And let me just emphasize, I think the UMA's role with the UAPA is one of collaboration, working together, and really emphasize partnering and teamwork on this, so that the end goals of quality of care and caring for our patients, really, I mean, that's what it's all about, is met, and we can get the, I love the PAs, frankly, and they know that because I've worked with them on the Hill and at HHS, because it's such a vital role the PA profession serves in our healthcare system.
Thank you.
I could speak to some of those points if that's okay.
How about
John?
2 minutes? We've got a lot of comments pouring in here.
Absolutely.
I want to get to these.
And I don't mean the mental health discussion to kind of take over, but the proposals right now, by the way, we've met with UMA last Thursday over a virtual meeting. We had 3 of their psychiatrist members of the psychiatric subcommittee of the Utah Medical Association. We've also met with the psychiatric nurse practitioners, and we began this process about a year ago. So we've had an ongoing dialogue, and the requirements have been kind of the point upon which we're all talking. And so there's been a real effort to dive in and really be specific about what that would include. Some of the things from the slide was 4,000 hours of supervision while they're getting this training. So that it would also include obtaining the CAQ, an extra board exam, which they'd have to resit every 10 years. Something unique about the PA version of this is that they have to also maintain their general medical knowledge. And so they have to continue to pass their 10-year NCCPA general exam in addition to their mental health training and their mental health verification. They'd also receive 1,000 hours of supervised therapy from a licensed therapist, and to pursue a curriculum that models the curriculum that is that directs the psychiatric or psychiatrist training during their 4 to 5 year psychiatric residency. So we're hitting the same content, and really what we're looking at now is very robust. It may not be that every PA wants to do this. This is going to take a couple of years at least to do on top of their PA training, to work in a more autonomous mental health role. But fortunately, I'm in a position where we can, where we're looking at programs, see what a program can deliver, and we're hoping to set a precedent for the nation in developing this kind of postgraduate training.
Can I just ask a couple of questions? Because I have been approached by PAs around the state that have actually not known that there were mental health PAs. And one of the questions was, how soon do we expect to start training? And what does that look like? And also, how do you propose that you get the word out about more mental health PAs? Because really, it's there's not many PAs that know of that's available. So how are we going to get the word out to those PAs, I think?
Oh, excellent. Well, I think the first thing is that we hold a summit with some really outstanding people that will draw the attention of our state and nation. but also really I'm the director of a psychiatry track. But this program does not meet the requirements that so far the psychiatrists want, and so we'll be hoping to achieve that, and soon, hopefully within a year, maybe within just a few months of trying to develop curriculum that will meet that. But not just for Utah, but for the whole country. And I've been in contact with national PA leaders in mental health. We're actually a pretty small group. Only 1.5% of PAs work in mental health. So we know each other. And so we've been in contact and trying to develop more language that will substantiate our role in this space.
Terrific.
Thank you.
Thank you.
I'd like to turn our conversation, if I can here, to some of the commentary that's coming in from our virtual audience. And we want to thank once again all of you for your participation. Our first question comes from Marie Pittman, and she wants to talk about the issues and benefits of the Modernization Act. She states, I've worked as a PA in different roles for 7 years and can see the huge benefit for the healthcare system in general with these requested changes. It helps us to work to our fullest potential per our training, and also shows the PA profession abilities that many have been demonstrating for years. With these suggested changes, what issues, if any, do you foresee? And then the second question is, what are the largest benefits in particular, do you anticipate? So I guess as you hear the presentation on the Modernization Act, how would you respond to Marie in terms of what are the I guess anticipated benefits, but also what are some of the challenges that may cause friction in trying to do something like this? And Michelle, you've had a great deal of experience, in your practice of medicine, and you've also been involved in kind of starting this from scratch, as it were. And you might be uniquely situated to talk a little bit about where people will see benefit, and also where they might feel a little bit of the grinding of the gears, if I might speak metaphorically.
Okay, I think what we're going to run into is we're going to have to educate. It's going to be a little bit of a pushback because we have always worked as a team. We've always had a supervising physician, and right out of the gate, it's not going to be understood. I've heard from several of the physicians, we've talked this over a little bit, and the one thing they said is, we don't want you to become independent practitioners. We don't want you to sever those ties. We've enjoyed our working relationship. And so I think education is going to be a big part of this, making our supervisors understand, our physicians, that we still want to be a part of that team. We are going to see benefit in that we can bill independent of our physicians, and that's huge. I think that saves money in the long run. When I first started in southeastern Utah, it was labeled as frontier medicine. And my supervising physician actually was about 90 miles away. And the state of Utah said, we can't do any better than this. There are no physicians to supervise you in frontier medicine. And so I actually had my own practice. And that was just a little bit of a novelty in Utah, and it didn't come easily either. There were physicians that were quite upset about that and said, you can't work as a physician. I said, I'm not working as a physician. I'm still a PA, but I'm in frontier medicine and nobody wants to drive 100 miles to supervise me. But it is really going to be helpful in rural Utah, especially when you do have those great distances. And it's not always easy to find physicians that live in those rural areas. It's very, very hard to recruit physicians. Oftentimes their families don't want to move to these very rural and rugged areas. And so for PAs, this is going to be, that are practicing in rural Utah, it's going to be a huge boon to be able to have that independence and be able to work at the top of our skill set without having a physician that maybe has just been trained in emergency medicine, and you can do obstetrics, or you can do family practice, you can do all these different specialties, and your physician really isn't comfortable overseeing that, all of our skills. So it really does help us to reach our full potential as far as our education and skill sets.
Now, let me go back to something that you mentioned there before. So Tim, are what the PAs proposing here, are they proposing independent practice? Essentially, is this a valid concern from other people? Is this in spirit, or is this in purpose? PAs striking it out alone?
That's a great question. A lot of people ask, what does this mean? Is this similar to what other non-physician providers have done? And the answer is no. This is better than independent practice. This is interdependent practice. We're redefining the parameters by which the team is working in law only, not in practice. We're just trying to remove some of those administrative barriers that have long been there and have made our physician colleagues uncomfortable and our employers uncomfortable. So, for instance, in my work setting in the Indian Health Service up in Fort Duchesne, Utah, I have a clinical director who also happens to be a physician, and he's phenomenal. He does OMT. He's an osteopath, and it's a wonderful way for us to reduce the opiate prescribing that we have, because he uses his specific skill. I don't know how to do OMT, so I send all my patients to him for OMT. I've been trained in CBT, and so I can help patients who are dealing with insomnia, say for instance, and offer the training that I've received to do CBT-I, which is now kind of the new better than Ambien type treatment for insomnia, and has less side effects and no abuse potential. So that's becoming the standard of care, but there's not that many people trained in it, but I happen to be. But when I do that and spend an hour with a patient providing CBT-I under my supervising physician's license, who is not a psychiatrist, our facility loses money. We cannot capture that revenue.
So Tim, I guess the question that needs to be posed in all of this, I think the principles that you're talking about are just fine. But how do you ensure, without that specifically delegated relationship from a physician to a PA, how do you ensure that what you're talking about actually ends up happening in practice?
So great question, John. And I'll take a stab at this, but Michelle or if anyone else wants to jump in, they feel free. The practice of medicine is highly regulated. For instance, if you want to open a clinic, if you want to have insurance working at your clinic, if you want to be able to order things, you have to be credentialed. And so the credentialing process at the employing institution requires that their providers be privileged. And that requires that usually a physician, I think in all cases, a physician has to see what that provider can do safely and then privilege them for that. Dr. Shiozawa is an emergency medicine physician, and he could probably take care of all of us in the event of a code. But I can't. I'm a terrible intubator. There are some that are great, but I'm not one of them. And so he would not privilege me to intubate any of you, and I'm glad for that. So there's a process in place already at the employer's level whereby all these things happen. And they happen for physicians, they happen for nurse practitioners, and there would be no change to that. This is just, for some reason, unintentionally, PAs have been left out in this process and given extra steps to prove our effectiveness and our ability to practice.
And you probably, correct me if I'm misspeaking here, but the employer is not even the only one who is going through this credentialing and verification. Are there not also steps at, for example, if they have admitting privileges at the hospital, or even third-party payers who would also put them through similar process? Am I correct on that?
That's absolutely right. So you won't get paid if you aren't privileged by the payor or the insurance company. You won't be able to run a practice very effectively if you don't get paid. So there's the insurance companies, there's the DOPL board, which will be there to put the kibosh on anything that PAs are doing that they shouldn't be doing. So there's continues to be regulation and supervision. So this is really just one layer of it that we're talking about, simplifying, modernizing.
Chris, I wonder if I could get your response to what he's talking about as an administrator. And when you look at these things from a policies and procedures, point of view, is what Tim is describing something that is feasible, that is acceptable in terms of making sure that the appropriate provider is doing the appropriate procedure for the appropriate patient at the appropriate time?
Yeah. So you're specifically referring to like a credentialing and privileging process to regulate practice of somebody, so to
Correct.
speak. Yeah. And, a lot of our physicians, NPs, PAs, we're all beholden to these ongoing professional performance evaluation, OPPE requirements through the Joint Commission, through different hospital-based, be it physician or nurse practitioner or PA. We're beholden to those standards. And so we actually go through pretty significant processes to establish proficiency and competency and to define that at a local practice site. That's how it has to happen through the Joint Commission and through CMS regulated processes at present anyway. So I think there are those checkpoints in place that help us regulate practice and what people do. And, for example, on a particular procedure, if you haven't done enough of them in your 2-year credentialing timeframe, there's a process for that. Typically, whatever the process may be, but you've got to show proficiency or competency again, or in those numbers get looked at again. So to answer the question, I do think we do have checkpoints in place that help with that.
What would happen if a PA was doing something for which they were not credentialed or privileged?
There's, as members of the medical staff in some institutions, in different areas, different hospitals have different approaches to that, but there are bylaws that govern those things, and there would probably be a disciplinary process that may involve likely some sort of a process within their file. They have, in many instances, hopefully fair rights to be able to have a meeting about it, to talk about it, but it certainly happens, and we have processes in place through the medical staff bylaws to help with that.
Dr. Shizawa, following up on that thought, he's speaking about kind of internal self-regulation, but there are also mechanisms of external regulation of the profession. And I think we can point to the Division of Occupational and Professional Licensing, as well as the certifying bodies that are, of course, private organizations, but nonetheless hold control over their credential. Is what Mr. Heyer talking about here, when viewed in combination with some of these other external regulatory forces, I guess to say nothing of the just self control and professionalism that is governed by that. Is that sufficient, or is there more required in order to have all the members of the healthcare team feel like, no, the PAs are not going solo and going rogue, as it were, but they remain as part of the team and they remain within their scope? Sorry, that sounds like a White House correspondent question. I guess the question then is, given these things we've talked about, is that sufficient, or is there more yet required?
You actually ask a very good question. And when you look at a regulation, whether it's through DOPL or it's a law that's going to be passed, the whole point of that is what? It's quality and patient protection. So you get the right procedure or the right medication given at the right time to the right person. And whether it goes through credentialing at a hospital level or through the medical staff or through DOPL or through some laws that are passed, the whole point is patient protection, insurance of quality. I'll tell you that this modernization is actually a very apt term. The existing law or regulations do need to be modified and updated. They're clunky. And the intent of having a supervising physician was, well, we're there in case, for example, when I supervised the PA who was in Green River when I was in that situation, we could talk on the phone. And so he at that time could call up and say, I have this patient who has a particular problem. Do I need to send him to the ER, or am I okay doing this? And it was a good collaboration. On the other hand, in the more and more doctors and physician assistants are employed. And so a lot of times you'll show up to work for a shift and you won't even know who's the attending doctor on that. And so trying to get signatures and getting this collaboration between physicians and PAs who don't know each other is really something that we need to make more streamlined and more efficient, because ultimately it affects billing, it affects the quality of care and the efficiency of our system. And so while we keep those in mind, I think there is some very, very interesting merit. Look, if the PAs want to take on liability, fine. I mean, I'm happy to share liability. In terms of independent billing, I think, especially in an employer-based situation, I think that can be worked out. Now, when you're in rural situations in a doctor-PA relationship where you have a much closer tie, then again, that's something that CMS and the state will have to work out. And as long as that's allowable and is appropriate and within federal guidelines, I don't have any particular problems. But I think we get back to the same thing. The external forces, whether at the hospital level, clinic level, or at a federal level or a state level, are there to protect the patient and have people, and doctors too, to act within the scope of practice. Let me just, I know I'm going a little long here, but let me just say, I have worked with PAs who've been worked on hospitalist teams, on trauma teams, who've been interventional radiology teams, and they're vital. And it's frankly, it's a lot easier sometimes to talk to the PA than it is to some of the attending specialists and to get things done. And they, many times, the PAs could do things that I either didn't have time for or the skill set to do. So this interdependent, and I like that term, interdependent practice, is I think a very worthy goal going forward, and it will help with equality.
As I listen to your responses, the thought occurs to me, and maybe I might float it out there. Would it be fair to say then that it's the intention of the PAs to continue their collaborative relationship with physicians rather than simply saying the physician?
I think that that's an excellent way of saying it.
Does that give them, in other words, it seems like you're looking for the flexibility to, collaborate with the physician who's on call right now with me, as opposed to trying to find the one who's tied to me who may not be here today.
Absolutely. I'm so proud of how PAs have do really two things really well, I think. Is one is they fill gaps. So if there's a physician who maybe doesn't do CBTI, there's a PA that might, and they can do that. Here's my colleague over here, Michelle, she does obstetrics. I've never done OB-GYN in my career, but she's done it. And she was late getting here because she was helping with the delivery just last night. She's filling gaps so that a physician can have some quality of life, so they can do what they do best, and she can help out. So removing barriers to allow that gap filling to occur is great. The other thing is that I was told by one representative from organized medicine that PAs were not trained to practice medicine alone. And on one side, I agree with that statement. On the other side, I disagree with that statement. And let me clarify. On the disagreement side, I would say PAs are trained to practice medicine wherever they're at. And we know that they can do it wherever they're at, within the scope that they understand. And that's well defined, and they're very safe providers. And we can show statistics all day long about malpractice rates and things that reflect that safety of the care that's delivered. And we're the first to call and say, this is out of my scope. I need some help. On the part that I agree with is that PAs are trained in team care, meaning they are experts at team care. That's what we do well. We collaborate, we work, we're not islands to ourselves. We want to partner with physicians from different specialties to deliver the care that the patient needs. And that have the skill sets that we don't have, because it's all about the patient.
Thank you. I want to go to a question here from our audience that follows up on this issue. We've spoken very well about the issue as it relates to larger organizations. Mark, from our viewing audience, states, the credentialing and privileging policies apply to hospitals and large employers, but would not provide an oversight for small practices or an individual PA opening their own practice. Let me turn this question first to Michelle. I think that you've had some experience in this arena. How would this, the application of what we're talking about look at a smaller practice level?
Well, again, I don't think that we're going to open our own practices and become independent practitioners. The same rules apply, the same relationship is going to be in place. And I think it does allow for us to have different supervisions, particularly in smaller practices or rural areas where there's not always a physician available. He may be on vacation, and certainly in Utah Navajo Health Systems, we went from 2 providers to 28 providers. And so there's always a physician available. So for us, for people working in rural medicine, and especially Utah Navajo Health Systems, there's always a physician there now. There wasn't always. But I don't think it's going to affect small practices. I think you will still maintain a relationship with a physician. There's still somebody that you can go to collaborate with, to discuss cases. I don't see this. I don't see PAs opening private practices and doing this and going rogue and doing this on their own. The collaboration is still in place, and there's still going to be physicians that are going to be very much involved in patient care and collaboration. Dr.
Shizawa, you're quite familiar with healthcare in the rural parts of this country. How do you see, I guess I'll use the words compliance. How do you see compliance taking form as far as these policies that are being, proposed, so that, essentially we don't have, providers who are out doing, things that they ought not to be doing?
Well, again, compliance, regulations, all are the game to ensure quality for the patients, and also for legality, to make sure we don't overbill or do something that's frankly not ethical or illegal. Compliance is certainly possible, and as long as we stick to the principle of interdependent practice like this, then that will help, so that there is some collaboration, supervision, if you will, in a team-based practice. A doctor practicing out and blending on his or her solo is just as much at risk of having issues with quality as a PA or nurse practitioner might be, or who is out in a rural setting, or frankly in an urban setting, without that close relationships. And then at that point, if there's complaints, and unfortunately they usually come in the form of a bad result or of a patient outcome, or maybe overbilling or billing issues, those are the 2 most common. Then you get the feds and the state people getting involved, and that becomes, and at that point we've lost. So what we want to do is to have this relationship with well-trained physician assistants, well-trained doctors in their relationships with him, and having a meaningful relationship. So you're not just signing off on something for someone who you don't know, or for some patients of which you either have no interest or have no relationship. And so that team-based thing is going to go a long way by ensuring, as you say, compliance, which is also another word for ensuring quality.
Sure. And so it sounds like, if I'm hearing what you're saying, is that we would want to make sure that as you implement this type of an act into statute, that I guess the question that forms is, how do we define that relationship? Do we maintain still this idea of the delegation of services agreement, or how does that look? Perhaps, Chris, you have some insight on this with other professionals as well, and perhaps you might offer some of your thoughts.
Yeah, I did have the same question. I think Dr. Shizawa speaks to this really well, on the importance of having well-trained PAs and well-trained physicians and NPs all working interdependently as a team. I think is frankly how practice happens currently, certainly in bigger systems. I do wonder what sort of the thinking is around how to, the example you raise of a PA standing up a solo practice.
Let me interrupt you there, because we also have other
Sure.
Practitioners, non-physician providers, who do open up their own practices. How is it that they're able to do that and not run afoul of these same issues?
You mean like a nurse practitioner?
Sure.
Well, they're not required to have any collaborating physician in most instances. So they're able to do that. And so I'm still trying to learn, I think, what the proposal is on how this act addresses that. I think to your question, what the limitation would be of a PA standing up their solo practice. How would collaboration with a well-trained physician and the right physician work in that instance? I don't know. I don't have an answer for you.
Do nurse practitioners within your system collaborate with physicians?
They do. Yeah. At Intermountain Healthcare, we identify a collaborating physician for them, even though in many instances per the state, it's not required.
So I guess what I'm asking here, Tim, is there anything in this law that would prevent employers from, establishing this kind of relationship that Dr. Shizawa is asking for?
Oh, well, no, of course not. This is just to do with the state statute. Employers are going to do what they're going to do, and no matter what we say, or they will do what they are going to do, and it's in their best interest as a liable party to do it right and provide proper oversight and proper collaboration. So, is there a role for non-physician providers to own a practice and deliver care? In some circumstances, there probably will be, and there is. And there's some nurse practitioners doing great work. And they're the first to tell you that they have a scope that they feel comfortable working in, and they have collaborators, and they refer and consult. But this law, what we're proposing, is nothing to do with PAs owning practices at all. And there's nothing in the statute about that in the modernization statute.
I'm glad that we've been talking about the concept of supervising, because we have multiple questions that have come in regarding our newest colleagues and those who are still in training and those who yet will enter into training and potentially could enter into this kind of an environment. The question, and I'll use the one that is posed by Wade Anderson. He says, PAs will need some kind of supervision when they first transition from school to the workforce. What are the ideas for that transition as they practice or transition into a practice of this kind of an environment that you're describing?
Well, if I may, I'll take this one. This has been something the UAPA has been meeting with directors of the PA programs on this very topic. And we're working on language to try to define that in a way that works to everyone's advantage, so that the program directors don't feel that they're releasing their precious graduates into an environment where they're going to fail, and because they won't have the support that they want, that they need, and all of us need, no matter what profession we're in. When we get out of school, we want to have a structured learning environment where people can really become profoundly efficient. I mean, physicians have got this down. They have really defined what a residency looks like and their competencies. And PAs are not proposing that we do something different. We want those students to be mentored in a meaningful way, perhaps even more meaningful than what we have now. And so we're trying to find that space. And of course, we'll be happy to include the UMA and other physician colleagues in that process, because frankly, the system now doesn't always work well for providing the support that these new graduates need.
Thank you for your comment on that. So do we take it then that when the language of the bill emerges, that we can anticipate something in there as far as parameters for the supervision of our new colleagues as they come into practice?
Yes.
Glad to hear that. Yeah, that's been a small concern that I've heard from a few different partners and myself included. Just how are we going to handle new graduates with this? So yeah, I'm glad to hear you're meeting with the program director, having that conversation.
Any other thoughts from the other panelists?
I think one of the things that UAPA can do is maybe create education for organizations or physicians that are taking on new graduates. Maybe define the role of the PA, because people have been in practice a long time or have worked very closly with PAs. They pretty much know how they fit. I've seen a lot of practices assign a mentor, a shadowing a partner, if you will, and they get an amount of time where they can follow a mentor and start to feel comfortable. But for organizations, new organizations or new physicians that have never really worked with a PA, isn't that our obligation to teach them how to utilize a PA? We don't just throw them out to the wolves. I think that a lot of that is going to come from us as an organization teaching these new organizations and new physicians how to utilize PA, how do you work with one, how do you collaborate with one, and now we have this whole new Modernization Act, and we're going to have to clearly define, what this means to a new physician and PA partnership.
There's a member of our board that actually brought the profession to another country, and I bet she would be well qualified to help us in that process, because we would love to hear how that happens. And that's a great point, that physicians are so well trained, but they don't always know what to do with another member of the medical team if they haven't been trained with them. Many PA schools happen in association with other medical schools, and they do work with them and they do know how they work, but many do not.
And a funny story is, when I first got to the UK, it was maybe a couple of weeks, and I saw a patient in one of the practices who I knew had esophageal cancer. And I called one of the specialists and I said, I need to get this patient in right away. And I said, I know he's got esophageal cancer. He's losing weight. He can't swallow. We went through the whole thing, and I said, I really need you to see him and get a scope. And he said, I'm sorry, who are you? And I said, I'm Michelle Lyman. He says, you got a funny accent. And I said, I'm Michelle Lyman, and I'm from the United States, and I'm a PA, thinking this guy at National Health Service level would know who I was. And he said, I'm sorry, but I don't take orders from, a personal assistant. So there was a lot of education for the first year on what PAs did. And we were very careful not to use the term PA, but physician assistant, because they really thought we were just personal assistants. We're going to take orders. So the education is just, having worked through several healthcare systems, the education is paramount to what we do.
Absolutely.
Folks, we are getting towards the end of our time here. There's one question here still remaining that I think we have time to go over here. And one of our colleagues out in the audience here, on the topic of the Mental Health Act and specifically prescription drugs. So Tim, maybe I can direct this one your way. This comes from Colby, who asks, is there anything in the works to remove the restrictions on PAs preventing us from ordering/procuring controlled substances for in-office use in Utah? He says, I currently have to rely on a physician or a nurse practitioner to order for me so that I can administer those in the office. That's a rather specific question. I wonder if you have an answer for that one.
Oh, that's a really good question. I presume this individual probably works like at a methadone clinic or something, where they just do dispensing
Yeah,
there.
my
at the
apologies.
office.
They don't indicate it in their question.
The short answer is that is an issue which we are now becoming aware of as the academy, and so that's something we can talk about. But no, there's nothing in this current legislative proposal that would include dispensing narcotics in-house. But that's something we can certainly talk about if that's seen as a barrier to care by our whole medical team and by the patient community. That's something we can talk about. I will say this though, medication-assisted treatment with buprenorphine saves lives. And the only I do it with patients in the Indian Health Service, and it has given lives back. It doesn't work for everybody, but it works amazingly well for certain people. And the only reason I can do that as a PA in Utah is because my supervising physician also has his DEA waiver. And I think of PAs that I'm training right now and requiring them to get this training in MAT therapy in our graduate program. And they go out into their work environment. If they don't have a supervising physician or collaborating physician that also has the waiver, they can't prescribe and they can't get that medication into the community. And so I do want to say that this legislation would hopefully overcome that obstacle to access to buprenorphine containing products.
Thank you for that. I want to make sure that everybody in the audience.
Jonathan.
Oh, please go ahead, Dr. Shizawa.
You know, when I was the regional director, I took the course. So I got my DEA waiver, so I can prescribe MAT, buprenorphine. Not because I ever intended to do it, but I wanted to see what type of training was required in order to be able to prescribe that. And that's a pretty good program in terms of educating the prescriber in terms of what it does. And if it's not already part of the curriculum for the PA programs, I would encourage strongly that that's one of the graduating criteria is MAT training, so that when he or she goes out into the world in terms and meets up with, whether it's in rural Utah or urban settings, that they can, or at least know what it is and can prescribe it if they feel it's appropriate. So thank you for doing that and including that. Thank you, Jonathan.
Well, our time is growing short here, and we're not going to be able to get to all the comments, and we've had several late ones coming in here. What I'd like to do with our remaining time is take just a moment here, because I think that this has been both an explaining as well as a learning type of session, and I think that there's some benefit in a little reflection on just what has transpired. And if I might ask you perhaps to ponder just for a moment on your 3 takeaways as far as the most important points from our discussion today. Is there one of you who maybe wants to offer up your 3 takeaways?
I'd be happy to. And well, as the president of the UAPA, I have to say my role is to listen. And what I've heard in our panel today is that we need to make sure that we're providing a lot of education about not just this act, but really about the PA profession and our role in the healthcare system of Utah. A second piece is we want to be able to define for our physician colleagues what collaboration will look like if it's any different than it is now, because they want to be a part of, we want to be on the same team. So to make sure that that's well listened to and well defined. And another is that mental health issues are on everyone's mind, and for improving access. And the better we can do that, from at least our little piece of the pie, we're only one provider class, but the better we can do that, all the better. And I, from what I've heard too, it's not just about those complex internal medicine psychiatric settings, but it's also about rural Utah and primary care settings. How can we increase access there to not just access, but access to quality, well-trained mental health care? So these are all points on which we hope to be able to clarify, define it as a group in a shared effort with our physician and other colleagues.
Thank you, Dr. McQuarrie. Anybody else feel ready?
I would say that education is key as we move forward and promoting this new modernization act, that we educate not only the public, but also that we support and really get in touch with the PAs in the state. I time and time again realize that as I'm talking with them, I was just on my way up here and talking to a couple of PAs that really didn't even know this was happening. And I thought, where have you been? but also, where have I been? Where have I been and not telling everybody about this? And so that responsibility lies on our shoulders to educate everybody and make sure that we're in touch with our fellow PAs, no matter where they're at, and that they understand, and we answer their questions and we help them. So education is key. I am excited about this Mental Health Act because so needed everywhere in this country, from rural to urban areas. We have to have, and to the big cities, we have to have that mental health care. And so I think promoting this and educating our PAs, especially extending them, giving them the ability to extend this care, is so important as we move forward. And finally, I think that making care accessible, it wasn't a really strong thing that we talked about as much today, but I think cost effectiveness and accessibility is huge. I don't think that if you have access, that's great, but if you can't afford it, that's another problem. And I think that's something that we as PAs need to really be looking at now. So I think telehealth is inventive and wonderful. We used to dabble in that a little bit, but now I think is a golden moment for us to collect data as we use telehealth to say, how are we going to use this going forward? It really is a lifeline to people who don't have mobility or transportation. I was just reading an article that 3 million people cancel their appointments because they don't have transportation. So this telehealth is really a vital lifeline. So I think looking at effectiveness, the cost effectiveness and the accessibility is something we need to be addressing as well.
Well, Chris, Dr. Shiazawa, should we flip a coin to see who goes next?
Sure. No, what a great discussion we've had. I've learned a lot. I've certainly been educated, and just so appreciate the colleagues on the stage and the great questions that have been asked. I guess my take homes are, I'm really glad that we're thinking about our new graduates, our newest colleagues, that those conversations are happening. I look forward to seeing the language in the bill that addresses that. I additionally look forward to the language in the bill that will define really what these teams can and should look like that make the most sense for patients. I do think we have some opportunities to have some great discussions with our physician colleagues. I mentioned before, the utmost respect to have for some of the physician mentors in my life, and I think respecting their training and their backgrounds and the efforts that they put in to train us needs to be a part of this conversation. And how can we develop the right language that I think makes the most sense? I would say, I think in learning more about this act, and I'm anxious to see the written language, I don't think it actually changes practice in a great way at the delivery of care. But I do think we have some opportunities, I think, to make sure we're working closely with our physician partners and the opportunity to define that in the right way. Additionally, on the subject of mental health, I think we've all been affected by the suicide rate in Utah. probably something that hits home with many of us. I've been part of some of Intermountain's work on decreasing that suicide rate that we're leaning in on as an organization. I'm passionate about it. I think it's really important. And again, I think a lot of what's being proposed with psych PAs does have opportunity to help address some of it. Again, but I think in the right team-based care models where we're involving our physician colleagues in the right way and our APRN colleagues in the right way. So I think just it's a team-based sport, as I mentioned right at the start. I think we need to continue to think about how we work better together. I like the word interdependently that's been shared today. That's been a good phrase for me to learn and to think about and how we work together. And that's all I got. Thanks.
Dr. Shizawa, I believe the last word belongs to you.
Well, you said 3 takeaways. So let me give you my impressions. The first is all of us, whether we're physicians or physician assistants, need to collaborate, and we need to be able to have meaningful training that gets us ready for whatever practice we're going to do. But we also have to be able to collaborate. And whether you're a family doc or an emergency doc, or you're a rural PA or an urban PA, maybe you're a trauma-based PA, whatever, there's got to be that collaboration. We need that. Independence, for the sake of independence, I don't know is worth going there, because this is a team-based sport, and for the quality of care that needs to happen, we all need this collaboration. And so I'm reassured that we're going to continue these ties. The second is the PAs are so important in achieving those 3 things that we talked about: affordable, timely, high quality access. Mm-hmm. There's not enough docs, for example, in the Tri-County area to take care of that patient population. Certainly not enough psychiatrists. So let's train physicians or physician assistants enough so that we can take care of this population. And so they don't have to drive 300 miles or suffer the consequences of not getting the care. Let's get this care available to them. And if we do it by telehealth, and by the way, we were able to get the emergency telehealth waiver prolonged, and so we're happy for that. But that's going to be a new normal. Telehealth is here to stay, you guys, and educating our PAs and docs in using this is going to be important. Then the third and concluding thing is, in this bill as it goes forward, whether it's the mental health bill or the Modernization Act, they're probably very important and have some aspects that should happen. But the one thing that will be really important is to guarantee the quality of education of the PAs to get the certification to go out and do that. They don't have to be more trained than the nurse practitioners, but it's got to be at least equivalent, so that this trains the PAs enough so that they can deliver this type of care. And I think if you can do that and demonstrate that, then that will go a long way to reassuring the medical profession and the public, frankly, of the merits of this.
I want to thank the members of our panel for your thoughts. My takeaway from the commentary is that we have seen, I think, the birth of a new hashtag interdependent practice. Spread it across the internet. An event like this does not happen overnight. It takes many hours and many hands. And on behalf of the Utah Academy of Physician Assistants, we would like to thank specifically Deidre Henderson, Jennifer Coombs, Kim McFarland, Tim McCreary, Brian Shizawa, Michelle Lyman, and Chris Heyer. We also would like to acknowledge members of the board of the UAPA who have been working tirelessly behind the scenes: Verlena Silva, Sandra Stennett, Katie Swenson, Brad Pace, and many others. We thank the Sheraton Hotel for the lovely facilities. We would like to thank Envy Incentives and In the Event planners for helping us to produce this very fine summit. To everyone who has tuned in today and to our guests here at the hotel, we say thank you so very much. We look forward to our future collaborations as we move these ideas forward. And we wish you all the happiest of PA weeks. Thank you.